This session is focused on developing an implementation strategy for your state. And we've heard in the previous two sessions some excellent presentations from folks that are already doing transition and have been doing it for some time. And we want to be sure to try to make the connection between that experience and what you do when you leave here today and you go back on Monday and start thinking about how am I going to implement this new process in my states. Some of the key questions are who should lead the process. The indication this morning was that perhaps it would be the state Medicaid agency or the state Medicaid director that would be responsible. They could either designate somebody in Medicaid or in an operating agency that does the case management and transition itself, statewide, regional, or local. There are all different models in the different states. These are the list of organizations that might have a role in it, and you'll have to figure out which ones it makes the most sense to include in your state, and it might vary from state to state. And who's going to be in charge? Is somebody going to be designated to not only receive the referrals, but who's going to follow up to determine whether they were actually acted upon and what happened to them, what was the outcome? This morning and this afternoon session, we heard different states have different infrastructures, and Don Lambert mentioned that selecting an agency to be the lead contact agency might interfere with existing patterns. Does that suggest you should consider designating just one contact agency or maybe more than one? And how do you deal with the silos if programs are spread across a number of state agencies and they all need to be integrated at some point in this process? So there are a lot of decisions to be made and things to consider when you're doing this. And to help you make those decisions, we're going to hear from Valerie Cook, who's involved with a new transition initiative using the ADRCs in the state of Michigan. Then we'll hear from Mary Malik, who's from New Jersey and is part of the Community Services Agency there under the Department of Aging and Department of Health and Senior Services. She was involved in the pilot test in New Jersey and might have some interesting perspectives on how, with their years of experience doing community transition, that pilot might have. And then Donna Mazik is a transition coordinator. She'll talk about her role as a coordinator and what she's learned over the years. And then we have Terry Mata, who is with the QIO in Rhode Island, and she was extensively involved in developing the new MDS 3.0 and is here as a resource to answer any questions that you might have about how it affects your role in this project. So Valerie, you want to start?
Good afternoon. I'm not sure I'm up to the challenge to be that exciting either, but I'll do my best. Just to clarify, I'm actually from Minnesota. I think Bob mistakenly said Michigan. We need to go a little further west to Minnesota.
Did I say Michigan? Yeah.
Well, it starts with the same two letters.
Yeah. I think it's getting to be a long day for everyone. I'm just going to talk about a new initiative that was passed in Minnesota in last summer. And even though it's not identical to the federal Section Q rollout, I think that it's very similar, and that I'd like to share how we plan that initiative. And we just launched it live this month, so we had the luxury of about 9 months to do the planning work, which you might not have at this point, but maybe we can, lessons that we've learned can be helpful to you. Just to briefly describe the initiative. Before I forget to mention it, I did put 2 handouts on the table back there to your left at the back of the room if you're interested in a little bit more information about Minnesota's program. But what we did is Dr. Greg Arling from Indiana University did a lot of research for us in Minnesota on nursing home utilization rates, and that's the basis of our initiative. We used the findings from that study. He was able to identify certain characteristics in an MDS admission assessment that's highly predictive of a successful community discharge. And so we're using the algorithms that he developed and running all of our admission MDSs through the system. And if somebody fits this targeting profile, that they have a probability score of 50% or higher of a successful community discharge, we watch to see what happens. And if we don't see evidence of a discharge occurring in the first 60 days after admission, then we at that point is when we flag that we want to provide some transition support. So that's the basics of his research that we are applying in our initiative. So just to back up a little bit, so how did we structure ourselves to do this? The whole initiative is a partnership between, I'm from the Minnesota Department of Human Services, the Medicaid agency, and I work in the nursing facility rates and policy area. And my colleague, Krista Boston, we're lead partners in this effort, and she represents the Board on Aging and the ADRC leadership piece of this. And so what we're doing is that we at DHS are doing all of this upfront work with the MDS analysis, et cetera, creating these profile lists, and then we are shooting that out to the local ADRCs. Each of the ADRCs, we've hired a dedicated community living specialist to be serving as this role in transition support. And so they will be the ones that will be contacting the nursing home to offer transition support and find out if in fact the resident is still there. And so we've got this partnership going between the two agencies, each playing a key role in this program. One of the things that when we were designing the program, we tried to think about gaps, because Minnesota's had in place for several years. We are not a money follows the person state, but we do have transition programs in place for those folks that are enrolled in our Medicaid programs. And we didn't want to duplicate those efforts, but we felt like the real gap is our private pay. As the private pay people in Minnesota were not receiving services, even though they're typically entitled to like a long-term care consultation or things like that, they typically don't get it. And I think a lot of private pay people they resist purchasing those kind of services, even though they can do that. And so our program is really geared towards private paying senior citizens. And our goal with this is to target those folks early in their nursing home stay before they get all settled in, because as a reminder, they look like a lot of people that did leave on their own. So that's why we wait 60 days too, because we don't want to waste our resources. We want those naturally occurring discharges to just keep happening as they currently do. We're going to target those people that look like they should have left, but for some reason they have not. And so if we do that, get there early, while they still have community ties, hopefully still have their homes, this is where we're going to try to start the education right at admission to, you're likely to come here, recover, and be ready to go back to the community. So those are our key messages. The other gap that we identified, and this was not, I have to admit, we didn't think of this initially entirely at first as how important it would be, but when we engaged the nursing home in our planning process, they pointed out that they're very good at discharging people, but the problem is they don't have the resources to do the needed follow-up in the community to maintain that discharge. And so many of these folks end up being readmitted to the nursing home, or in some cases back to the hospital. And so we're putting a lot of effort in this into follow-up, and as we mentioned, haven't failed to mention, we're using the Eric Coleman transition model that uses hospital to home, but we are using it in the same kind of a context. Identifying key areas where follow-along and intervention is needed to continue a successful stay in the community. So our program will be doing an in-home visit within 3 days after discharge, and then we'll be follow-up phone calls, 14 days, 30 days, 60 days, and every 90 days thereafter, just to, as a check-in, find out if anything is going wrong. The 90-day evaluation is also going to be used as a part of a 5-year longitudinal study, so that we can, is our targeting profile effective? Are we using the right characteristics? How are the protocols and our interventions working? And we're also testing our fiscal projections. We projected in the first 5 years that we would save $25 million with this program, and that's how we were able to get funding to actually do this program. And because it went in as a budget savings, and so we want to test that. And where we get the savings is delaying spend down is the idea. If we can get folks back home while they're still private pay, would do some counseling about, demonstrating how much money that they can save and have more funds, their own funds available for much longer if they, spend it wisely, buying some home services and things that make their stay at home more safe. And so that's the philosophy. And so the $25 million in savings is net after the administrative investment in staffing and running this project, and also there is assumptions that these folks do spend down eventually and will participate in some of the home and community-based waiver programs. So that reinvestment has been considered in there. So we're hopeful that it'll be a pretty successful program. So lessons learned, I kind of talked about, where we came from, the history of our thinking, and how we started to plan this. And so one of the things I think would be really clear is, who are you targeting? Be really clear on who you're targeting with your efforts, because I'm sure everybody does not have a lot of resources. In the Section Q model, of course, it's helping you, who you're targeting. But if you're thinking about this more broadly, you might want to look at the research and see, what are the characteristics of those people that are most likely to leave and be successful. And then secondly, I think you've heard that many, many times today, was engaging the stakeholders. One of the things we did is from the very beginning, we had nursing home social workers, administrators at the table with us, and we learned a lot from them. And they better understood what our goals were, and together we were able to develop all the protocol, assessment instruments, marketing materials, communication materials that I think really served us well in the long run. And the third thing we do, I think, that is really going to be important is we establish a very robust data tracking system so that we use the MDS at the front end, but we've also built in all this follow-up tracking that's going to occur after discharge. But it'll be easy for us to, evaluate even the referrals coming from Section Q, the is our targeting criteria needing to be tweaked. And so we intend to do a very robust data analysis as this programs unfold over the next few years, so we can try to fine-tune some of those questions. That's my sum up. So I will turn it over to the next speaker, and then we'll have time for questions at the end.
Good afternoon. I'm going to talk to you a little bit about how we started up our Community Choice Initiative. You heard at lunchtime how we started up the pilot, and of course it was an expansion on what we're doing already, but just to give you a little idea how we started things up in New Jersey. The Community Choice Initiative was launched because of a grant from the federal government for NIF transitions. It was a 3-year grant. With that money came education, marketing, and the ability to hire staff to go into the nursing homes. That's not always feasible today, but back in '98, we had the funding to bring in these extra staff to do the counseling. We started with a group of 6 counselors. We developed marketing items. We had outreach. We went to the senior centers, the AAAs, the hospitals, the nursing homes. We had PowerPoint presentations. We developed our website fairly early on, and we had plenty of written materials that were dispersed throughout the community. The thing I think that was lacking initially is that, they got the grant and they just hired the staff and we went out into the nursing homes. There was not that initial collaboration with the nursing homes. This is what we're doing. They got a letter telling them about the Community Choice Initiative and that the Community Choice counselors would be out visiting them. And lo and behold, we arrived at their doorstep with our PowerPoints in hand and all our materials about discharge to the community. And, we were welcomed very cautiously at first, sometimes very suspiciously. Sometimes, like, what are you doing here? But for the most part, they were cooperative and accepting of our program. And especially when they realized that we weren't going in there to pluck out all their residents. We weren't going in there to empty the nursing home or force anybody to leave. It was a collaborative effort. We were working with their discharge planner for any individuals, that expressed a wish to return to the community. Primarily, we focused on the Medicaid and the 6-month spend down individuals for options counseling. That we did not ever turn anybody away. You know, if a person in one bed heard us counseling a person in another bed, or they started talking about why we were just there, oftentimes we'd get a referral to come in and talk to them. The social workers would of course, our community choice counselors are always interfacing with the social workers in the nursing homes, but the nursing homes, the social workers frequently gave us the names of individuals they wanted us to go up and counsel. We had physical therapists that made referrals. Nursing assistants would make referrals to us. Say, want, you know, Mrs. Such and such in whatever room, she would really talking about going home. She'd like to talk to you. So, you know, eventually when they realized that we were there not to empty their nursing homes, they developed more trust in the relationship. And when we took the message to the nursing home, the community choice counselors themselves were the ones doing the presentation. So they were going to the nursing homes where they were going to be working. And oftentimes, you know, they already knew the community choice counselors because of our pre-admission screening activity in the nursing home. So we were building and expanding upon a relationship we already had with the nursing home. So I really think that helped pave the way. You know, I can't emphasize enough that the importance of, you know, communicating the message, educating your own staff and the nursing homes and the community about the program, and collaborating with these entities. You know, when we first started the Community Choice Initiative, the training that the counselors went through was phenomenal. We met, there were 6 of us to start. We met weekly. We talked about, you know, the barriers we had, the successes we had. We case conference cases. We grew into a group of 50. At that point, we were having monthly meetings, and again, you know, we were case conferencing complex cases. What did you do? What resources did you have in your part of the state? And we brought in a lot of formal training as well for the counselors when you're starting up these programs. We had the SILs come out, DDD, mental health, the Medicaid waivers and Division of Disability Services. We even had someone fly in from Washington who was a well-known author and expert on care management and NIF transitions. So there really was a huge education effort to educate the transition counselors, and then bring a lot of that information out to the nursing home discharge planners. Now, of course, they're never going to know all the myriad of programs and resources that are out there. And they do really rely very heavily on the community choice counselors coming into the nursing homes, you know, to work with them about hooking up with different services. So I'm going to now turn it over to Donna. She's going to talk a little bit about NIF transitions.
Hello, everyone. Good afternoon. My name is Donna Mazik, and I'm a community choice counselor, and our office was chosen as a local contact agency. And as Mary emphasized, the community choice counselors are already in the nursing homes, so we have already established relationships with them. But I just wanted to share my experience as a transition coordinator and working with the pilot with the MDS Section Q. With the referral process, the social worker would just contact me directly, and she would give me the names and information and demographics of the clients. She would also give me the reason for admission and the projected discharge plan and the primary contact. And based on the information that I received with discharge, the discharge plan, then I would base the information I received and develop a plan or discuss options with the family and the client. Because I couldn't go in and discuss every option, so it was based on the information that I received. And when I went in to see the client, I would also talk about finances and resources, because now we're also targeting clients that are private pay. So I have to also focus on resources that are available for them as well in the community. So that's how I geared my options counselors towards each client. It was individual, so you can't, you just have to base it on what the information that you're given and what the family and the client wants, or what they desire, and if they desire to return to the community, what's available. The differences between the transition coordinator and the social worker, I believe, is because we're a state entity, we have connections with other state agencies. We also work closely with the Office on Aging, the Centers for Independent Living, the Board of Social Services, the Veterans Administration, and now we're also starting up our ADRCs as well in the county. So we have more connections and more resources available to us. And because we have offices in the north, central, and the southern part of New Jersey, if someone wants to move from the southern part of New Jersey and transition to a county in the north, we have contacts there as well, and people we can tap into for resources that's available in that county. So that's the differences, because I know there was a question during the first session about what's the differences between what a social worker is doing with discharge and planning and a transition coordinator. And we just look at it from a community perspective. I always go in with the open mind that it's feasible for everyone to return to the community until I get more information. So I always go in there knowing that this client is going to return to the community if that's what they desire, and I desire to make it happen for them. And that's about it.
Terry, do you want to say a few words about Rhode Island's experience?
Yeah, I'm going to kind of go back a little bit to what was talked about this morning about the 2.0. We know that there was a question on the 2.0 that pretty much asked about a preference to return to community, but that there really wasn't any teeth behind that. And I think what MDS 3.0 is kind of add the teeth behind that to actually do something with that information. It's not to say that there weren't people that were doing anything with the information. I think it's like with any kind of form or any kind of process, the people that are actually behind doing the process make a big difference. Some people are more motivated to do that. Some people are not so motivated to do that. So I really think that 3.0 does actually kind of push that in the right direction. Like I said, as with any change, it can be challenging. The QIOs have their challenges. I'm from the Rhode Island QIO. All the states have their challenges, especially with the fiscal reimbursement going on. But one of the things that I think has come out clear in all of the different sessions is that you kind of have to know how to use your resources, and you really have to collaborate, because that, I think, is the only way that we're all going to kind of survive together. So in Rhode Island, we have a Medicaid Global Waiver. It's kind of a big, huge umbrella waiver that takes all of our Medicaid stuff in, and we're in the process of rebalancing. Part of that rebalancing is part of that is a nursing home diversion program. Our ombudsman office handles the nursing home piece of that. There are nurses that go out, it's very similar. They get a referral, they go out to the hospital, they go out to the nursing home, and they do their level of care there. I think it's gotten to a point where they're actually going to bring that into the Department of Health and Human Services, and I know there's some folks in here from Rhode Island who can correct me if I say anything wrong. But that's one of the things that they're doing. So they have the nurses that are going to be within the Department of Health and Human Services to do that. We also have a very active long-term care coordinating council that is run through our Lieutenant Governor's office. And when of course, because it's a long-term care coordinating council, they were very concerned about the Medicaid Global Waiver and how that would impact the long-term care residents in Rhode Island. So what they did was they convened all of the discharge planning folks from the hospital, from the nursing home, whoever was involved in discharge planning. They also brought in the trade associations in Rhode Island and sat down and talked about, okay, we know this is coming, we can't stop it. What can we really do together to make sure that it gets implemented properly, care gets delivered properly, and in the right place? Because we know that some of these folks really can be transitioned out. So that's one of the collaborations that we had. And being that it's the Lieutenant Governor's office, it's high enough in the state where some of the things that happen in that particular meeting really do get to the top people in the state of Rhode Island. I know last year, and I don't know if any of the Rhode Island folks have anything more recent than this, there were 81 referrals, and I'm sure there's more now, 81 referrals and like 14 placements. And I think there was only one person at that point, this is kind of old, but there was one person at that point who couldn't go out, and it wasn't because they weren't eligible. The problem was the co-share in the community. So they were going to go back home with a spouse, and it was going to increase the co-share, and financially it just wouldn't have worked for them. So the person had to end up staying in the nursing home. Another resource that people might consider, CMS has a scope of work for all of the quality improvement organizations in the country 14 of them are working on a care transitions project. Part of the care transitions project deals with nursing homes and how they discharge folks, hospitals, how they discharge folks. The people that I work with are some of the nursing homes in Rhode Island, and we're working with them closely to identify areas where they can kind of beef up and enhance their discharge processes. So when Valerie was talking about following up with people and how difficult that can be, and that they've put a process in place to do that, one of the care transitions models, Eric Coleman's care transition model, has a process where there's a care transitions coordinator or coach who goes into the hospital, meets with them once in the hospital, and then sets up a home visit to follow up to ensure that they've got the information that they need to self-manage at home. That's one way of doing it. In the nursing home, what we're doing is trying to provide them some tools in their discharge planning process to kind of beef up, doing that same type of follow-up. They're not necessarily following the care transitions model to a T, but they're taking some of the tenets and working with those. And I think the only other thing I would want to say is that we kind of have to be kind with each other, because there's a lot of fear out there. The nursing homes on their side feel like they're gonna get a huge drop in census because of this. From what I've seen, at least in Rhode Island, that's not happening. So I think you kind of have to reassure them that the goal is not to drop everybody out of the nursing home. The goal is to have a proper placement and make sure that those people are in the right place for the right care.
Okay, thank you. How about some comments from you folks on what your plans are, or questions of these folks about their programs? Oh, come on.
My question is to the folks in Minnesota. I'm intrigued by the fact that you used your data from your MDS to trigger the initial contact with folks that had not appeared to be transitioning. When you encountered those folks, was the data validated? Did in fact they have a desire but not a plan to return to the community?
We are just launching this, so it's very, very fresh, so it's hard for me to answer that question. One thing that we were concerned about false positives in our list because discharge tracking forms might not have come through yet. But our initial experience, it's only been anywhere a rate of about 10 to 20% of the folks on the list had already been discharged when we called. And we were pretty pleased with that, because it's not that labor intensive to make a phone call and find out that they're already gone. We're willing to make that effort so that rather than waiting too long before it's too late. Because our research shows that somebody that's been in the nursing home 90 days, very, very slim chance that they will leave. The discharge just completely flattens out. So we're erring more on the front, on the front side of false positives, and that's what we're going to really be watching now over the next few months. Maybe we need to move that up even a little more. We'll have to see.
Thank you. Another question from Minnesota. What's the basis to project a net savings of $25 million?
Well, again, that was based on the research study that Dr. Arling did, and then he built a model using our claims history. So, we were able to look at our history of admission, how long did it take for a person to spend down, and what were their characteristics, and he was able to build a model that our forecaster was willing to accept.
Yes, some others? Could each of you identify your thinking or expectations for how you will designate, or which agency you'll designate as the local contact agency?
Ours is already designated through our global waiver, so it's our Department of Health and Human Services. And
Which one?
Rhode Island Department of Health and Human Services.
The department?
Yeah.
Oh, and I think you mentioned in the earlier session that they had contracted out the transition coordinators and they were moving them in-house?
Right. My understanding is they're kind of going to bring them under the DHHS umbrella.
And in New Jersey, we're using state staff. the pre-admission screening staff. Of course, the grant ran out a long time ago, but the staff is in there in the nursing homes, community, and hospitals doing pre-admission screening. So we just expanded the scope of what they are doing. And you know, it is a stress on staff resources. We have to see how things unfold, but right now we are relying on state staff to conduct the options counseling for all these individuals.
In Minnesota, it'll be the designated agencies will be the ADRC, which is branded as Minnesota Help Network, but it's one phone number that that the referral can come through, and it's just automatically routed to the ADRC center that's assigned to that area. The community living specialists that will be working on this transition are ADRC staff, and so they each have nursing homes assigned to them based on their location.
So if somebody is a Medicaid eligible beneficiary and they look like a good candidate for the waiver program, would they also be referred simultaneously or even before they come through through the ADRC system to the managed care plan that they're a member of?
Well, I think in that situation it could come to us one of two ways, either through our identifying them with their admission assessment or coming back through for us as a Section Q referral. And what we plan to do in that case is to do the same follow-up to the nursing home to find out the transition status. Because in Minnesota, if they're in Medicaid, they're most likely in a managed care plan and would have an existing care coordinator. So we would just be following up to be sure the care coordinator is in the loop and planning a transition. And once that transition takes place, they will also participate in our 90-day follow-up calls because they came in through the targeting profile.
Thank you, Bob. I have a question on training. Donna, you mentioned how important training is and that you did a lot of it. And am I gathering that your local contact agency is yourself, Department of Health and Human Services in New Jersey?
Well, it's Department of Health and Senior Services.
I'm sorry, yeah.
It's the Department of Health and Senior Services.
It's the department.
And in our office is the professional staff are nurses and social workers, and we have an office in the southern region, the central region, and the northern region. So all the agencies will be considered local contact agencies under the Department of Health.
That's interesting. So and then my follow-up question is, what about training, say, in Minnesota, Val? Have you done this kind of training with your ADRCs and also in Rhode Island? So that's what I was just interested in. Did you do the kind of training that Donna is speaking about that happened in New Jersey?
Yes, we did extensive training as well. We actually used ADRC funding, grant funding, to be able to hire these community living specialists sooner than we would have been able to if we had to wait for the state appropriations to do that. And so we actually brought them on probably about 6 months ago. They go through, they've been through rigorous training. I believe it's Boston University Certificate of Gerontology. It's an online program that they all go through, and there were some specific modules that were selected for them, and they've been meeting regularly and building that kind of network, I think, that other folks were talking about. So the community living specialists have been together for quite a long time already, but they also go through and get all of the training required for the knowledge on all the Medicaid programs, long-term care insurance, because part of their role is to also provide that sort of information, particularly for private pays. What are your private benefit options that you might be able to access, and also assist with applying for public programs if they're getting close to that situation. So they really needed a very broad set of training. And we were lucky enough, that might be because of the state of the economy, we got some very qualified people that come, some really very good matching backgrounds. So that helped us too.
I have a question to actually all of the group. in instances where there is inequity of resources, maybe urban to rural, or where you're confronted with waiting lists for folks who are interested in transitioning, I'd like to hear any responses to how what your strategy is to deal with those inequities in terms of resources and dealing with waiting lists.
When you're talking about resources, are you talking about like housing and things like that resources, or?
Any long-term service or support, as simple as a meals program, as complex as housing, any of those things that can complicate or delay a transition?
Well, we do anticipate that we'll have some barriers to transition because of access of services and probably some of the very remote parts of the state. One of the things that we're doing with this data tracking system is capturing why did a transition not occur, and if it's due to lack of services, I mean, whatever the reason, we're going to capture that. And we'll use that data to help us with our state's investments in building capacity in the community. So we have a program in place, community supports development grants, that we can use this information to help better inform where those investments should be. That's one thing that we're considering as far as dealing with that.
And I might add, in New Jersey, housing is always an issue, but at one point we had even purchased housing vouchers for a disability initiative that we'd run for younger disabled population. So, but housing continues to be a problem, finding subsidized housing for the mentally ill, just an ongoing problem.
And in Rhode Island, I know, again, I mean, housing, I think, is a big problem across the board. We have a global waiver task force that includes housing folks on it as well. So they're looking at Section 8, some of the waiver beds or some of the waiver slots for assisted living. They're looking to expand those. So I think there's a number of opportunities that will come about, but I know it's a big problem.
I think you also have to think creatively about how you can deal with access to services if there's a waiting list for waivers. The renewal application format allows states to reserve slots for people who are transitioning. There may be some other mechanisms, like Texas's original money follows the person, using the appropriations from the nursing home appropriation to pay for services in the community and basically allow people who are transitioning to get ahead of the waiting list from people living in the community. So it's a barrier. And there's also an interesting strategy that the state of Connecticut did when they had one of their early nursing home transition grants. They actually identified barriers and tracked the impact on the length of time it took to transition people who were facing different barriers. Housing obviously was had the longest impact, and I think it delayed the transition for 18 months or 2 years or maybe longer, but I'm sure Don Lambert would be able to give anyone who's interested in figuring out ways of identifying the impact of barriers to transitioning some links to get that report. I saw somebody else had a mic. Yes.
Next question is capacity of staff. If you're using ADRC staff, they already have so much to do. How are you dedicating additional funds for additional ADRC staff, or if you're using current resource or relocation specialists, are you hiring additional ones? And if so, where are the additional funds coming from for the additional staff capacity?
Well, in New Jersey, we're using existing state staff. I couldn't see who was being the question, but we're using existing state staff, and it is a challenge to keep up with transitions, especially when the counselors are out there doing pre-admission screening. The hospitals, of course, take a priority getting in there to do the screen, so they're sort of fitting in their nursing home work in between community visits and hospital pass. But they're doing a pretty good job of it, and they're in the nursing homes a couple times a week for the most part. They're in there for transitions, they're in there for global options, IDT, transition meetings with the interdisciplinary team, the resident, their family, and the care manager where they'll be discharging. So it's a challenge, you know, to have enough staff to go around. But you know, so far we're fairly well keeping up.
I think in states that have existing transition programs, the volume might not be unmanageable, at least initially, so that's some comfort. But in states that don't have them, it may be higher. I don't know.
Now, with Section Q, including the private pay population, I was wondering, Val, you had mentioned that you've had some extensive private pay training for your counselors, your ADRC staff. My ears kind of perk up when I hear that because I know the private pay population is really new to us because we've mostly been dealing with those who are financially eligible for state-funded programs. So I was just interested in some of the training that you provide for your staff related to private pay.
Well, I think one of the most interesting tools that was developed actually by one of the local AAAs before we started this effort is what we call like a cost calculator. And it's just this very simple one-page resource, but it's very effective. It's a really strong message that, you know, that a private paid person could look at it and go, wow, you know, if I just make these investments now, because it compares the costs of, you know, of home-based services to assisted living and to a nursing home. And, you know, and I don't think that people always understand what those implications are. And so, you know, that's one thing I think we're trying to get the private pays, you know, to make some more informed choices earlier in their decline. But we would be happy to share that tool.
Is that on your website?
I wish Krista was here. If not, we'll get it on there. There's a website on that one handout back there. On the back of the two-page summary of the research study, there's a website at the bottom. So I'll look into getting that tool on there.
We have time for a couple of more comments. Yes.
Yes, this is for all of the panelists. I'm wondering if any of you have involved peer counselors and options counseling, or peer-to-peer bridge specialists, peer mentors.
Not in New Jersey I believe in maybe some of the other divisions there's some, especially mental health, there's some peer counseling, but not in our particular division and what we're doing.
I'm not familiar with the term.
I guess that would be a no. I think, Donna, you mentioned some avenues for doing peer-to-peer training between the councils when they meet weekly and go over the difficult.
Actually, Mary spoke about that, and that was initially when they started up the Community Choice Initiative. The counselors met weekly to share their experiences, their challenges, and what was effective and what wasn't. So that was very helpful. And then as they became more experienced, then the meetings went to monthly, and that lasted for about 1.5 years.
Do you involve the experienced counselors in the training of some of the newer ones as they come on?
Yes. Actually, I'm considered like the options counseling guru, so I counsel and instruct and educate the new counselors that come on board.
And Donna goes out to the IDT meetings, the round table before they discharge to the community, especially with the new staff. They're not real comfortable with themselves yet, sitting at the table and talking about the options in the community. So Donna makes herself available for that as well.
Now that I better understand what you were asking. While we're at the very early stages, we actually do have a conference call everybody together every day in the morning, and I think it'll go to weekly. It'll be the same kind of thing, but they also have an instant messaging secure system that they can use amongst each other and with us at DHS staff, and so that communication tool is very helpful as well.
Okay, I think it's the magic time of 2:30, so we're scheduled for a break before the next session. Thank you all very much, and thanks to the panelists.